Let's get started. So good morning, good afternoon to all. I'm Jonathan Fuchs. I'm the Program Director, Principal Investigator at the San Francisco Department of Public Health Capacity Building Assistance Program, get SFCBA, and joined by our colleagues from the Denver Prevention Training Center and California Prevention Training Center. And we are the West Region Learning Community Call with all of you. Really excited to see you all today. And we have a very exciting agenda ahead. We're going to be talking about optimizing PrEP adherence and persistence, kind of the state of the science and lessons learned, and really excited to have our colleague, Dr. Rivet Amico, who will be joining us and leading off with the discussion, leading off with a conversation about what we know about PrEP adherence and persistence, and we'll have an active discussion. We'll then turn to our colleague, Cheryl Malinski. She's a nurse practitioner with Seattle King County and is going to talk about a unique mHealth approach called WellTel to support PrEP engagement. And then very excited to invite our colleague, Dr. Albert Liu, here at the San Francisco Department of Public Health, and talking about our intervention, PrEPmate by WellTel, a mobile health intervention to support adherence, PrEP adherence, and engagement in care. And then we'll have some closing remarks. I did want to share just a couple of announcements. As you, I'm sure, have already heard, there's updated CDC PrEP guidelines that are now available. We posted the link in our group site, and I'm sure it's been distributed through a number of channels. So please, if you haven't had an opportunity to take a look at those, we recommend you do. And today, hot off the presses, at 4:30 p.m. Eastern Standard Time or 1:30 Pacific Time, you could register for a webinar that CDC is hosting featuring Dr. Dawn Smith, who will be talking about the guidelines and the recent updates. Before we start, what I'd like you to do is, if you can, share your names and organizational affiliations, and it is the holidays, so your favorite holiday song in the chat. So if you want to share that, we greatly appreciate it. I'll stop sharing here, and without further ado, to start off our session today, I'm really excited to introduce Dr. Rivet Amico. She's an associate professor at the University of Michigan School of Public Health, and she's been working for over 2 decades in treatment and prevention, and is really excited to share this update on optimizing adherence and persistence, what we've learned. Rivet, you have the floor.
Great. Thank you so much. I get to steal some time on thinking about my favorite Christmas song. I would like to start out just by apologizing. I am working from home. I do have 3 dogs. So we're going to work with this as best we can. It's really a pleasure to be here with you all today to talk about adherence and persistence, really focusing on what we've learned. So we've had a lot of new information come out to date, and then turning the conversation towards what we might be able to do to optimize. So what I'm hoping to be able to cover with you today, and I did want to start my timer, stand by, there we go, is talking just about terms, right? Adherence, persistence, also known as continuity, and prevention effective PrEP use. And then pull from the literature in terms of what are we seeing right now in terms of rates of mostly persistence, because that's better represented in the literature, and rates of adherence in kind of real world settings. Touch on some approaches to optimizing PrEP and prevention in general, talk about a couple of things in the pipeline, and then turn it over to discussion. In full transparency, I'm certainly not covering everything that's available out there. And what I'm hoping to do is to just cover enough for us to be able to have ongoing conversations. And those conversations can lead to talking about, pieces that you would have liked to have heard more about. So without further ado, I did want to just take a moment to position that we are talking about persistence and we are talking about adherence, but we're all very well aware that PrEP involves a process, and it involves multiple interactions that change over time between communities and sources of PrEP. And preventative care more generally. And, I think we're all using status neutral models at this point, but when you really position where persistence and adherence lives, it's fairly down the pathway. And it is important for all of us to be thinking about in our work that we do have ongoing challenges in terms of equal distribution of awareness of PrEP as well as access to PrEP, and we have ongoing inequities in use of PrEP that need to be addressed. So just a little on terms. So adherence. When we talk about adherence, we're almost always talking about doses taken as recommended, or at least in the case of oral PrEP, that's what we're talking about. And as some of you may remember from back in the day, when the randomized controlled trials were going on, there was a clear indication of a dose response. So for oral PrEP to be effective per these randomized controlled trials, you really needed to take it. And they weren't quite sure yet on how much you needed to take, but if you're in a trial, you're really asked to take it exactly as recommended throughout the entire course of the trial. And some of the bumpy rollout of PrEP really centered on, oh my goodness, what if adherence is as bad as it was in some of these randomized controlled trials, right? And I think we're finding out that that's not the case, or as concerning as it was originally. Adherence kind of morphed it for PrEP into, well, maybe we need to be thinking about, are you taking enough doses as recommended to get protection? And we know from subsequent work with gay and bisexual men who have sex with men, as well as a smaller proportion of transgender women who have sex with men, that it depends, right? So it could be that you don't have to take every single dose, but maybe 4 doses a week are enough. And we know that that's not the case for cisgendered women. And that is going to be less forgiving, and potentially even less forgiving in times of pregnancy. So we're still kind of learning about this. But ultimately, I think we're coming to a more precise definition of adherence being that you're taking enough doses as recommended to get protection when needed. And that's really consistent with Jessica Haber and others, proposed in about 2015, this idea of prevention effective adherence, right? And that's not just, are you adherent, but are you adherent at the times in which you may actually have exposure to risk? Now, that's a pretty hard thing to measure in real world practice, right? Because you need to be able to know what doses are you taking, but then you also need to know what kind of risk exposure you might actually be having, because it's the two of those together that really define prevention effective adherence. And that kind of leads to persistence in some ways, because if you look at the data that's kind of coming out, I think people are, doing prevention effective adherence in some ways on their own if they're starting and stopping in line with kind of their seasons of risk. Because when we look at persistence, it's generally amount of time on PrEP or time engaged with PrEP. And there's choices and decisions, and the more choices and decisions that come around with PrEP options as well as other prevention options, we can see changes in persistence that may actually be totally appropriate, may not be, but that's a question that needs to be looked at, and changes in situation. And so in terms of adherence and persistence by the numbers, we still have a lot to learn. Most information that we have available in the literature really comes from the coasts, and it comes from MSM. And less is known about other priority populations, but increasing amounts of information are out there. And again, particularly for persistence. And you can see why persistence would be easier to capture when you're using kind of medical records. I want to highlight a few of these just to give you an earmark towards what we really could be expecting in terms of persistence specifically. In this particular study, it's looking at 7,000 PrEP initiators who initiated in 2015 and looked over pharmacy records for a period of 2 years. And according to these estimates, 56% who started PrEP continued with PrEP for a year, and 41% continued for 2 years. And when they looked at what was related to continuity with PrEP, continuation was higher for men versus women, for those who were commercially insured, for those using specialty pharmacy to get PrEP, greater than 18 years of age, and had a copay of $20 or less. In another study looking at Kaiser Permanente clients in Northern California who had been linked to PrEP, almost 14,000 actually adults were studied between July 2012 and March 2019. And among those who were referred for PrEP services, among 88% actually went on to get PrEP prescribed. Really high number of those folks actually initiated PrEP, meaning they picked it up and started it. But among those, 52% stopped at least once. Now, interestingly, 69% of those restarted again. So you can see that as potentially being for reasons of stopping and starting if your situation has changed, for example. However, we do still see some discrepancies. So African-American Black individuals were more likely to stop and restart. Women were more likely to stop and less likely to restart. And neighborhood level factors and substance abuse disorders had higher discontinuation. So I want to go through just a couple more pieces of data. Oh, and I did want to note really importantly that among those remaining on PrEP, there were 0 observed infections. So again, with persistence, here's 7,000 people that members of the CDC looked at, and these were commercially insured. And they found that 75% of people that started were persistent, still getting PrEP at 6 months, and that dropped to 56% at 12 months. And when they looked at, on average, how long are people on PrEP, they estimated 14 months. And this is actually in the San Francisco primary care clinic network. 348 people were analyzed from 2012 to 2017. And Scott et al. Published about 8.3 months was the median duration from first start, or from start to first stop. And you can see here in terms of the drop in terms of days from initiation. So we're clearly seeing that there's a fairly sizable drop off. What I do want to note here is when the authors separated it by race and separated by ethnicity, some of the things that they found is that young Black versus white injection drug use and transgender women versus MSM had higher drop off. So we're more likely to discontinue from PrEP. So some inequities there. Couple more by the number. Okay, sorry, I didn't know if someone was saying anything. I'm not watching chat. Okay, here we go. 344 people evaluated for PrEP in a sexual health clinic 2014 to 2015, so a little while ago, but still what they saw was that 96% of PrEP was prescribed for all MSM, so 96% of all who had been referred, and every one of them identified as MSM. 78% had PrEP initiated, 47% stayed on PrEP. And one of the reasons I want to pull up this figure, which you would need glasses if you're me to really try to dissect, is that here we can see a real value that can be added by asking just some simple questions. So here we can start to look at, well, what are the reasons for discontinuation? And it's still dominated by no reason given. But after that, you can see cost and insurance, transferred care, change in relationships. So there are reasons why people are discontinuing or non-persistent with PrEP. And in other work in this area, they're finding that the most common reasons for discontinuation, whether that's a permanent or a temporary pause, is a change in risk and a change in insurance. So I don't want to forget about adherence. So what about adherence, right? We're talking a lot about persistence. And again, I think that's because that's a number that's accessible using data generated from pharmacy records, insurance claims, so on. The few studies, very few studies, have evaluated prevention effective adherence. One of the ones that did is in Australia, which was part of EPIC NSW. And they found that actually 99% among their MSM population appeared to be having prevention effective adherence. 72% had optimal drug levels, period, in PrEPmate, so not prevention effective, but just drug levels. And then 80 to 86% had optimal drug levels in the PrEP demo project. So when you compare that to what you heard early on in the randomized controlled trials, I would go so far as to say that adherence among people who are choosing this as part of their regimen for prevention is actually way higher than what we saw in the clinical trials. And that's for a lot of really good reasons that I'd be happy to talk to people about. But in general, we can expect about half of the people that start are probably going to stop at some point, at least, and that a proportion of those who stop might reinitiate again at a later point. And this is all daily, right? So you know, thinking about stopping and starting makes sense in that regard versus how one might engage with 211. which we'll talk about in a moment. But we definitely have work to do in terms of decreasing disparities by race, gender, resources, and age, both for access to PrEP, uptake of it, being prescribed it, and being provided support for ongoing use, or at least using it as long as they want it to be part of their prevention plan. So quickly, I just want to take a moment talking about optimizing adherence and persistence, really through services, support, and programs. But my soapbox / comment, before we do so, is that I really believe in highly tailored, community-centered, person-first approaches. And in that regard, I would argue we need to understand the reasons for our current landscape of PrEP awareness, use, and continuity. And we need to very clearly understand reasons for why things are happening that we're seeing, because otherwise the intervention strategies that we may pick and choose from, which there are many at this point, may make no difference whatsoever if it's not addressing an actual need in a community. And I like, this is Judy Auerbach's version of a unified HIV prevention cascade. And not so much the numbers that I want to pull out here, but I want to point out that we all have access to what our local cascades are. Maybe we can't do it in our community. Maybe we do have that data, but we certainly have it by region. We have it by state. And rather than kind of just going in with, we have a gap and let's address it with something that can effectively address the gap, I think when we're working in community, it makes a whole lot of sense to anchor our gaps onto the reasons. Right, so what are the reasons? What is happening? Is it knowledge? Is it risk perception? Is it consequences of use or fears around it? Is it social norms, for example? And there's many ways we know how to do this, right? Community consultations, focus group, community team members embedded as part of action teams, surveys, continuous quality improvement, many strategies to do that. And then you would yoke your intervention, obviously, to a reason for why it is that you might be seeing really low motivation or desire to use PrEP, or difficulties accessing, or lack of effective use. So again, that cycle of then being able to go back and look at your gaps, and these are all familiar to those of us doing continuous quality improvement, but it's a very mindful and informed strategy. There's work on reasons, right? This is a systematic review of adherence to oral PrEP, and you can see in this work, really looking at, well, reasons for poor adherence or uptake are really side effects, knowledge challenges, something about the regimens themselves, socioeconomic factors, stigma is pervasive throughout and is a real factor that needs to be dealt with across the PrEP cascade, and factors of daily life. And I always encourage people to focus on, ask why you're starting, why you're stopping, how has it been taking PrEP? Is it still right for you? So on. In the interest of time, I'm not going to go through the details here. It's actually available in the new CDC PrEP guidelines, but suffice it to say that guidelines have always recommended some form of counseling, some form of interaction between individuals to find out what's going on for them. And we have a lot of tools for that. And, whether that's providing basic education, PrEP facts, fact sheet, discussions focused on, it might be barriers based, it might be problem solving. I think by and large, that really is the basic package. But if we want to really address inequities and really create much higher uptake and use, we really should be adding in supportive outreach weekly, which we'll have someone talking about that with us shortly. Intermittent contact, again, monitoring. You can use many different monitoring tools like point of care urine testing, and do discussions around whether or not PrEP was detected. You can also do triggered outreach, like when someone doesn't show up, for example. There's many effective interventions, including PrEPmate now, which we'll be talking about today, that are available in the best practices list on CDC. There's also the WHO implementation tool that offers a lot of different strategies that you might consider using. But again, I would go back to whatever the specific strategy is, really should match the need of whoever it is that you're working with and the communities you're working with. The next step counseling, I just wanted to highlight as kind of a way of doing that with an individual, where you're really looking at what does this individual need, and then trying to really tailor your strategies to that. Additionally, we have a ton of, post-COVID or during COVID, we had to develop teleprep. I think there's amazing things being done with telenavigation. as well that can be really promising, and other mHealth based support, which again, we'll be talking about later today. I'll leave you with this figure. I'm not going to go through it in gory detail, but I think that just about every providing agency should be able to sit down with it and think about, what does my program do in these areas? What are we doing for access referral? What are we doing for adherence? What are we doing for follow-up and continuation? And everybody should have a working version one of these that periodically can be checked and seen whether or not this is working. Where are we having gaps? What are the reasons, and what might we be able to do? 2 really short points. 211. Still, it's not new, but it can be issued off-label. And I believe PrEPmate, I think, will be talking to us about that as well. I can say, though, a lot of knee-jerk kind of concerns at the initial thought of 211 was that, oh my goodness, no one's going to be able to be adherent. But data does support that people can and are effectively adherent to this regimen. And then long-acting injectables are going to be coming down the pike. That also has guidance around making sure that you have consistent conversations around it. Make sure you're talking about continuation with it, because you are going to have that long tail. That's going to be a point in which you're going to have to really try to leverage services to make sure that there's contact and make sure that people are, hopefully have prevention tools during that period of time. So that was my whirlwind. I can breathe now. And the main points are really just presented here, that PrEP is a process, right? And I think that our next real challenge is, how do we deal with intermittent use, and how do we kind of support it and optimize it? Preparing for these new regimens and choice being widely available, where people might go from one strategy to another strategy, and what does that mean? Really try to leverage those new CDC guidelines and try to adopt that goal that everyone should be aware of PrEP. And then you can think about who now wants it, and how do you support them. There's a ton of tools and strategies out there. I just think we need to really be strategic in which ones we're bringing to bear for who, when, and that should reflect community need, community center, person first. So by way of discussion, I know we had some questions. I think I will drop it in the chat as soon as I figure out how to navigate to my text, which I think I can do in a moment. So, what we're really hoping people can talk about is the trends that they've seen regarding PrEP adherence and persistence, where they're working, as well as PrEP decision-making, adherence, continuity, discontinuity, what's happening with restarts, how are people working with restarts. I think it's really important to think about, is it a failure, or are we working with trying to help people to incorporate that into their HIV prevention plan? And how's COVID affected engagement with PrEP care? And I just dropped those in the chat as well. So lots of questions, lots of information. Thank you for your time and attention. And I'd love to talk about this.
Very excellent. Thank you so much. It was a fantastic introduction to the topic, and you pose a lot of important questions. I actually would love to jump to the questions. Anshe, you had several here that are really relevant to trying to address what engagement or re-engagement might look like. I don't know if you want to come off mute and ask some of your questions.
Oh yeah, I feel like you began to touch on it when you looked at some of the challenges, or what are the reasons why some folks are dropping off. So thank you for sharing that. But I wanted to know, what has the re-engagement look like? Have there been any strategies for maybe identifying some non-traditional partners and thinking about persistence, right? I love that idea about changing situations. So it made me think about also changing environments, right? And what do we do to get other folks involved in this? So just want to know, what have been some of those strategies, and what does that look like?
That's a great question. I value what other people might have to share. I mean, I can jump in with saying that this is really one of the reasons why wraparound services and providing PrEP in the context of other preventative services is so key. Because if I discontinue PrEP, but you are offering me other services that I find of value, I'm not going to disconnect from you. And therefore, I have this opportunity to continue to have conversations. Oh, you're not on PrEP anymore. Is that still right for you? Are you thinking about time? Oh, is this so? You can check in at each time, and the priority becomes, not people on PrEP walking through our door, but people with a prevention strategy walking through our door. The flip side is, if that's all we have to offer, I don't think it's reasonable for us to think that people are really going to stay in close contact with us if they've discontinued. The other thing is, I think we need to come up with a whole script, a whole language around, not everybody remains on PrEP. What is it for you that's going to, is there like a point at which you're like, whoa, this is not for me anymore? And what are we going to do around that? And hey, there's safe ways of doing that and not, because if people feel like they're being a bad patient, that's another reason they're not going to reach out to you and be like, hey, I'm going to stop taking this drug. And how many lived examples do they have of that, right? We don't have many examples where like, hey, doc, I'm going to stop this antibiotic midway. Hope that's okay. Like, you're not communicating that. You kind of know you're doing what you're not supposed to be doing. So normalizing it as well.
And I just had one more question. You're just thinking about medical mistrust. And I feel like that's a huge barrier when we're thinking about PrEP engagement. What does that look like? And how have we begun to cultivate some level of trust? Or what does trust building begin to look like?
I love that. So the reason I think this is critically important is that, so we don't touch about awareness, right? We didn't talk about awareness or the PrEP decision-making process. And that's how people eventually get to PrEP adherence in the first place. And if I feel like I've been kind of pushed into making a premature decision, or it made sense at the time because the navigator was telling me, oh, it's good, it's fine. And yet I got out and my mother was telling me, oh, that's poison, or my brother told me not to do that anymore. Like, it's really important that we build opportunities and spaces and places for people to have a decision-making process through this. And that needs to be, talking about trustworthy sources, talking about, hey, what kinds of information would be most helpful, but also who would you need to hear that from? Because it might not be me, right? And I do think the mistrust, especially now in the context of COVID, in the context of a lot of other things going on, that's a head-on thing that needs to really be built by the community. But I would go back to thinking about what are the reasons, and then how might we be able to gauge in like community consultations and community work to have real conversations around it. So the reason I'm not giving you discrete strategies is I don't think there are any. I think it needs to be really tailored.
Great questions, Anshe.
Yeah.
If you don't mind just stopping the screen share for just
Absolutely.
a moment. Thank you so much. And the questions are in the chat. I also would love to hear from our health department colleagues about what are you observing and thinking about, either directly through funding to local health jurisdictions or to community-based organizations, in terms of what their experiences are around PrEP adherence and persistence. I'm wondering, Helen, just your experience in Montana, if there's anything you wanted to share about as you're trying to scale PrEP and what you're hearing about it, adherence and engagement and care over time.
Sure. Hi, everybody. I am the epidemiologist for HIV prevention and surveillance, and I had just started noting that we're pretty low morbidity, but that a number of new diagnoses had been on PrEP and then had gone off and then tested positive. So I was interested in this subject as a whole. One thing we're doing is a needs assessment of providers regarding their knowledge about PrEP, about who they offer it to, and then doing some focused interviews with people who recently tested positive for HIV to get their, to learn firsthand about what some of the barriers are in Montana. As you can imagine, we have population centers with infectious disease docs or people who might know a lot about PrEP, and then we have very rural areas with maybe just general practitioners who might not know quite as much. So if other people have done similar assessments, I'd be super interested in finding out. We're combining our HIV needs assessment with the hepatitis C needs assessment. We just got additional funding for that, and are coming up with our draft tool kind of as we speak. So it'd be really good timing.
That's great. Are there, so thanks for that question, Helen. Are there surveys that or in-depth interviews using kind of qualitative methods for people who have recently been diagnosed with HIV to kind of get a better understanding of current factors? And if they're on PrEP, what are some of the factors that may have influenced their, if they ended up stopping PrEP? Do we have any of those, any jurisdictions have samples of those kinds of questions? Al, I'm looking, I think we are doing that qualitatively in San Francisco, if I remember correctly. I don't know if you have any, particularly around PrEP, and if you have any comments on that.
I think we were doing some interviews of newly diagnosed. Willie's group is doing that. We do have a survey that we did several years ago assessing provider needs and strategies that they would like to be supported. So happy to share that questionnaire if it's helpful. It's several years old, but might still be helpful.
That would be great. I'd appreciate that. And I'll just close. I really appreciated the comment that not making people feel like bad patients, because a lot of times we'll review cases with Ryan White, and if somebody's gotten infected after they went off PrEP, they're like, oh, that's terrible. Why? I hate to see that, and I think we need to work with our provider and even our Ryan White case managers that, people aren't necessarily bad patients if they went off, regardless of the outcome. So I really do appreciate that. And that's something I'll pass along. And hopefully I'm not perpetuating that when we, review our patients.
Thanks so much, Helen. And Helen, I'll touch base with William McFarland, see if we can get some additional, interview guides that have been used, if that would be helpful. Great. Other folks want to just comment on what you're seeing in your jurisdiction. I know we've got a lot of folks here, and several folks have joined the call. So if you haven't had an opportunity to put your name, organization, and favorite holiday song, since it is the holiday season, we're going to put together our Spotify playlist. So yeah, please put your name, put that info in the chat. That'd be great. John, I see you. If you want to just any comments from New Mexico, any thoughts about PrEP adherence, retention, and engagement in care, kind of what you're seeing, any particular challenges, how that might be overcome, or how folks are trying to tackle that?
No. No, not really. No comments.
No comments on that. Okay. Good. Others want to comment or share their ideas?
This kind of leads to something that's been on my mind a lot, which is geographic disparities, not only within states, but just comparing certain states to other states. I wonder, I guess, first of all, on this call, if there are people in other states who feel like they have the support at the highest levels of their health departments for PrEP and for HIV prevention efforts, or if people are working with jurisdictions where that is one of the challenges. I find it's one of these awkward things when you work with other states or other jurisdictions if you come from San Francisco, because you kind of are always there saying, don't I have the prettiest dress? Because we know that San Francisco can do things pretty well. And the San Francisco model is not always right for some jurisdictions. And some jurisdictions are kind of openly resistant to hearing about how wonderful San Francisco is and how great San Francisco does things like HIV prevention or PrEP access. And so I don't know, I'm just posing this, that it's been on my mind of how do we overcome the geographic disparities in PrEP access and in these kinds of services. Yeah.
So this is John in New Mexico. I can actually talk a little bit about that because New Mexico, one of the largest states in the country, sparse population. So in Albuquerque, we have a good amount of PrEP providers, but then the rest of the state, is rural or frontier, and we don't really have, we didn't have PrEP providers. And we started working with our HIV Education Training Center, and they were going out and doing training sessions with doctors, to get them the education credits that all doctors and nurses are desperately craving every 2 years. But then they would take the class and then they would not offer PrEP. Because some of them were saying, we don't want to be known as the HIV doctor and stuff like that. And so what we actually did, it was like kind of a combination. I was like, well, why can't we? Because in New Mexico, all our public health offices are state run. We don't have separate county run health offices. They're all state agencies. So I was like, well, why can't, and with my boss, Andrew, we're like, well, why can't we offer PrEP out of our health offices? And so, because we have health offices in every county. And so we actually worked out a Project Spicy where we went and used contract money to hire mid-level nurses to offer PrEP out of each of the remote regions of the state, in Carlsbad, Las Cruces, Farmington, Santa Fe, and Northern, and so forth. And we tied it in with our STD funding as well by doing it PrEP and syphilis. So they do syphilis treatment, and that way we could use some of the syphilis money or STI money, as well as HIV prevention money. And then we are using the 1040B pricing to try and generate a little bit of revenue. That's before Gilead changes things in January. We were using that to generate a little bit of money there to help pay for the contracts. But in using those separate mid-level contracts, we were able to place a PrEP provider in an area where we couldn't find anybody at all for years. Because we tried for several years to get somebody in Roswell and in that southeast part of the state to provide PrEP. And so we just ended up doing it ourselves as the Department of Health. And it seems to be working out really well.
Great. Thank you. Any other questions or comments from the jurisdictions about PrEP engagement and care, adherence, what you're seeing, any potential barriers, and how you might be tackling them?
So to understand, John, you were saying that essentially you couldn't get buy-in from the providers, so you just went ahead and did your own prescribing. Is that accurate?
Basically, yes.
Yeah.
We talked to providers, and so then we got our medical director for the Department of Health. He did a standing order for PrEP, and we did protocols on PrEP and so forth. So we have a standard one for DOH, and that's what we're using right now with our Project Spicy nurses.
Yeah. And I know I'm not part of this particular SEBA, but it's not dissimilar from many places in the Midwest where we'll have like one provider. Although it did change in baby steps over time.
Thank you, John. Other thoughts about engagement in care and how that's been engagement in PrEP care and how it's working, what's been working effectively, where some of your barriers are?
Another barrier that I found too is that there are sexual health clinics that are what are called STD clinics, and I wish they weren't called STD clinics. In many jurisdictions are resistant to longitudinal care, which is what PrEP requires. PrEP is not episodic care, which is what traditionally sexual health clinics have provided, unless a person is living with HIV and is going to that clinic for their primary care. And so I think coming up with strategies to make PrEP care as easy as possible is one solution. I think we have done that in many places using express visits, using some kind of telehealth model for some part of the visit or some certain number of visits during, say, the year or something like that. But if the medical director of a sexual health clinic does not see them providing longitudinal care, that is another big barrier.
Right, Robert, thanks for raising them. I mean, these are key structural issues that I think are important if we're trying to think about ongoing engagement. And if you can offer longitudinal care, that's critical. And if they're, those are some important barriers that have to be overcome. I appreciate that point. Cheryl, I think it's a great segue actually to your, or Rivet, were you going to say something about that at all?
No, just going back to the application of that unified HIV prevention model of like many locations are going to have really unique and potentially quirky reasons for why. So you'll have these global, but sometimes like just getting in there and doing those consultations and needs assessments can really be helpful to identify low hanging from, you know, ones that are way up there in the tree that you can't really tackle.
And thank you. Cheryl, you mentioned, you know, you're coming to us from Seattle, King County, and maybe if you want to talk a little bit about actually your experience with PrEP adherence and engagement in care and some of the strategies you've used in addition, you know, including mobile health strategies.
So I work for the Seattle Health Clinic, and I've been working on PrEP for about 7 years. And I also want to say, Jonathan, you upgraded my education. I am not a nurse practitioner, but I appreciate that. I actually have a Bachelor of Science degree in health education, but I've been a PrEP navigator for 7 years at King County Public Health. And I was asked to talk about the system that we use. It's called WellTel. And just so everyone knows, I do not have any association with them at all, but it is a fantastic program that we use to help engage our patients in care. It is a texting system. And I'm so sorry, I've been sick out of work the last couple of days, so I have no slides or anything for you, so I'll have to describe it. But the texting system is really awesome. Our patients love it, we love it. It's something that we keep up on our desktop as a way to communicate with our patients, but also we send them reminders for their appointments too. So we send out a text reminder a day before their appointment and also a week before their appointment. And then we have open communication with them too. So they can text in and ask us questions and we can respond to those questions. But to kind of give you a general idea, the way the WellTel system looks, it's a grid, and on one side, as I was told Jonathan, I think of it as like a stoplight. There's multiple, you know, different grids, but there's yellow, red, and green. So when a text comes in, if it's green, it's not high importance. If it's yellow, it's more important. Obviously, if it's red, somebody has used a key phrase that says, you know, it's really important. And you can create your own data dictionary to alert your system on how to respond, to put them in which category. So when the message comes in, there's a little balloon that pops up in the corner, kind of like our chat there, and it'll tell us what we have messages, and we can communicate with the patient that way and answer any of their questions that they have. It also has broadcasting that you can send out a total broadcast to everyone that's on PrEP. This isn't something that we use that often because I'd like to think that we're not pestering our patients. You know, we don't want to, you know, we want to keep them engaged, but we also don't want to annoy them that they will ignore the texting, right? But there is that capability, and you can also break down the broadcasting to like special groups. So I also do research, so I can make a group of just people that are in research, and I can send out a message just to them about research purposes and stuff. We have a capability of what I call it's QCing. So there's a list of, you know, your patients, and it has all their appointment times on the screen that you can see. So what we use as part of the WellTel system is if there's a blank space, like somebody doesn't have an appointment scheduled, we know that one, either I made a mistake and I forgot to put that person's appointment in to remind them, or two, they missed their appointment. We need to get them re-engaged into care and make sure that they have an appointment to do that. We also, you know, I will say their customer service there at WellTel is awesome. You will never have better IT service than the people at WellTel. You send a message and they're on it. They're also great problem solvers too. So if there's something that you want that they don't have, they try to work with you to make sure that you get that. We just started doing a perfect example. We just started giving out 30 days of initial PrEP to people when they come in. And we wanted to make sure that we could send out a specific message to those people that got the meds to remind them that they still had to go to the pharmacy to pick up their next prescription. So there, you know, we worked with them and there's a way to do that. So in 14 days from when they pick it up, we set up this message that'll send it out to them and saying, hey, you need to go pick up your meds to do that. What else did I want to say? The system's really, really wonderful, but I think one of the things that why our people are so engaged, I guess I haven't told you, we usually carry at least 600 to 700 people in just our clinic. And I've been working at our PrEP clinic the longest, and we have people that have been in care there for 7 years at our PrEP clinic. So we have a lot of old timers that come into our clinic. And when I'm training people, I said, our job is to make their life easy. And I think honestly, that is one of the big key things in keeping people on PrEP. We do everything. So when somebody comes into our PrEP clinic, you know, as navigators, we figure out how are we going to pay for their meds, right? That's the first big thing and all, you know, and all that. But the next step is, you know, they're going to go to the pharmacy to pick up the meds. And there are a lot of issues that people have. And I think this is where a lot of people get lost in care and staying on because they don't know what to do. I've never realized, you know, until I worked on with WellTel, how many young men do not know what to do when their prescription is finished. Like they run out of meds. It's like, oh my God, what do I do, Cheryl? What do I do? And it's like, you need to call the pharmacy and ask for a refill. To me, you know, being a woman and I was on birth control, that was something that I knew, but a lot of young men, they've never taken a daily medicine and they had no clue this is something that they need to do. So, you know, it's really, you know, the WellTel system has really assisted us in that. Or there could be something as easy as, you know, there's prior authorizations, you know, and they come in and people don't realize, you know, if we don't hear from the pharmacy, the patients are telling us, and we can act on that and making sure people are getting their prescriptions too. Or there's troubles, you know, now that we have brand, you know, generic Truvada, when people are on the Gilead assistance, they have to have brand name meds. So typically if a pharmacy is trying to, you know, get meds for those persons, they're trying to ring it as generic. And of course that doesn't work. So then that causes a problem too, which, you know, can cause the people to get out of being on PrEP. But the WellTel system, like I said, it's really awesome. I mean, we communicate with people on that. People can text in questions. I always tell people, you know, you can ask us anything you want, you know, and they can tell us anything we want, but, you know, we have HIPAA constrictions on us. And I'll say, you know, if I can't say something, I'll say, call me, and, you know, they'll give us a call. But it really is a really great system. And I understand too, the people, I mean, we're great. I live in Seattle, so there is access to care for PrEP. It's very easy. And I understand these people in rural areas. We actually have people that drive in from Eastern Washington 4 hours away, which I think is just crazy. But I mean, it makes me feel good that we do that and people want to come in, but there should be access to care for those people out there that live in the boonies. You know, I mean, we just need to get care out there. And I keep on saying we need to get the DOH out there and contacting and talking to providers. I think it's really important. We're also starting a new research project with one of the young providers, and we're creating like a test kit that people can, you know, get their PrEP that way. But our people do come into us regularly for PrEP too. And I think that's really important too. They come in every 3 months, they see the same people. And I think that really helps out a lot in keeping people engaged. If we lose people, it's usually at the 1 month mark. And I think, as the provider was saying earlier, I think it's because people are not quite ready to be on PrEP yet. And the providers, you know, they're really eager to get on people on PrEP, which I think is important. But, you know, sometimes people aren't quite ready yet. And I think that's okay that if they're not ready. But every time they come in, I think it's important just to say, hey, remember about PrEP. And I think, you know, just to keep reminding them, you know, sometimes some of our people, it's taken them 3 or 4 times and then they finally get on it. And hopefully, you know, we get them on it before, you know, they seroconvert. But, you know, WellTel, you guys got to get it. I got to tell you, got to get it. It's awesome.
That's great, Cheryl. Thank you. There's a question from Robert, just about the cost for using the platform. Any comments?
You know, that I don't know, because I'm not involved in the cost, you know, and I don't know. We've been using the WellTel system, I think, when they were a pretty new company. I don't think it's cheap, Robert. I will say that. I don't think it's an inexpensive system. But it is, I think, if you can find something, you know, if you can get it, I know they're really great. They do a lot of charity stuff. Not that they would do that, but I meant they do a lot of wonderful things. And if you could get the state on board with doing something like that, I would think, you know, that would be a good thing. But it is all about money, right? I mean, that's the truth of the matter. We have more money because we're in the city, than other areas. And that's the truth of the matter.
Great. Rivet, you're going to say?
Yeah, I dropped the link to the WellTel website, and they are really responsive at like even just coming out and having conversations about what needs are and estimating quotes. They're small enough, and I think that's the part about being a new company that's cool, is that the original people that were excited about it are still there, you know?
That's who you're talking to. Is who you talk to all the time. I've worked with Gabby and Richard, and I think they're the main own it and stuff. And they're from Canada, and they're wonderful people. Like I said, you will never get better IT service than you will with these people. I mean, honestly, they are so fabulous. And I mean, that, you know, like I said, if they can do something to make it work better for you, they will. This is a system they do use in Canada. I will tell you, there's a lot of other capabilities that are available on this system that we don't use. I mean, frankly, we don't use them. You can do video calling and all kinds of other stuff because they use it for their healthcare system. And we don't use that access. Sorry, that's my clock going. Going off there in the background. But we don't use a lot of that system that they offer. I mean, we use it mostly for texting, reminders, broadcast messaging. People can send in photos, so it's great. So if there's a problem with their insurance cards, we can get pictures of their insurance cards and stuff like that. Like I was saying, the one young man doctor is going to be starting this sending out test kits. It's a new research project, and they're going to use the WellTel system for like video appointments too, which will be nice for patients and stuff. So, but I mean, I think it's really key, because I think this is where I think the reason more than communicating is you find out all the problems that people face just trying to pick up their meds. I mean, we do a lot of problem solving. You know, I've had multiple patients say, Cheryl, I know if I ask you something, you'll figure out it and you'll fix it and you'll make it work, you know, because there's, you know, problems with insurance and all kinds of stuff. So we're constantly on the phone trying to tackle those things. So it's not just even seeing the patients, it's just all the stuff you do in the background. But if you don't have that communication with people, then you can't do it. It's so much easier too than on the phone. I mean, I hate to say it, we have our own line for the PrEP clinic, and we, it respond to messages maybe a couple of times where the WellTel system, we have it up on our computer, and I can be on the phone with some insurance company and communicate with my patient and try to help them out, reschedule appointments, whatever it is, but I think if you can make it as convenient as possible for your patients, I think that's the key to keeping people in and people coming back. We do have people stop and restart, and anybody that stops and restart, we definitely talk to them about 211. So if somebody wants to leave, and because they're in a monogamous relationship or whatever, I always make sure, I always wish them well and stuff. But I say, if your life changes, you open up your relationship, remember, to come back to us. It takes a week before your meds are effective. If you have sex not that often anymore, remember there's 211. That's a great way to prevent you from getting HIV too. So we'll switch people over to that, offering people all the options that there are to keep them engaged and negative.
Great. Thank you, Cheryl. And I think it also great segue to Dr. Alu, who is the clinical research director at Bridge HIV at the San Francisco Department of Public Health. And I have the pleasure of working very closely with him, and also in close collaboration with WellTel on our PrEPmate intervention, PrEPmate for WellTel. So Al, thanks for joining us. And I think a perfect opportunity to kind of talk a little bit about some of that work, and highly complementary to what Cheryl has just shared.
Great, thanks, Jonathan. I am just going to try to share my screen. Great, can you see that?
Yes.
Okay, great. So yeah, I'm going to talk a little bit about PrEPmate by WellTel. Thank you, Cheryl, for providing such a great description of WellTel. So PrEPmate is built off of the WellTel platform. And we made some enhancements and adaptations to support PrEP use. WellTel originally was designed for supporting people living with HIV to support antiretroviral adherence. It was first tested in Kenya and found to be an effective tool. And so we we're interested in seeing if it could also help with PrEP adherence and persistence. And there are two types of messages that we incorporated into PrEPmate. First are the weekly check-in messages, which was part of the standard feature of WellTel, which is just checking in weekly. Hey, how are you doing? We added some more PrEP specific messages. How are things going with PrEP? But then we also added in the option of daily reminder text messages for taking, reminding people to take their medication. So these are messages that folks can set at the time that they, customized time where they take their medication, and they come in the form of fun facts or sex facts, LGBT quotes, as well as we have a section on trans history and trans specific messaging. And so people can select when they onboard onto PrEPmate, they can choose which types of topics they're interested in receiving messages about, and they can also change those over time. And the messages are available in English and Spanish currently. So we tested this version of PrEPmate in the EPIC study several years ago. This was in collaboration with a group in Chicago, enrolling young men who sex with men. It was a diverse cohort. The mean age was 24, about 27% were Black, 36% Latinx. And what we found was that, so people were either randomly assigned to get PrEPmate or the standard of care at their clinic. And what we found across 36 weeks of follow-up was that participants who received PrEPmate were more likely to be retained in care. So those are shown in the green bars compared with the standard of care. So about 86% of visits were retained in the PrEPmate group versus 71% in the standard of care group. And then we also looked at PrEP adherence as measured by the drug levels, tenofovir diphosphate levels, and also found that across visits that there were higher levels of protective tenofovir levels, 72% versus 57%. So, and the efficacy of PrEPmate did not differ by the participant's age, race, ethnicity, education, or insurance. So we did publish the results in Clinical Infectious Diseases, and as Rivet mentioned, PrEPmate is one of the evidence-based interventions and best practices for HIV prevention identified by the CDC. We have since really tailored PrEPmate for trans participants. We added a bunch more messaging and piloted it in a PrEP demonstration project for transgender individuals called the STAY study, where we enrolled 121 trans non-binary clients. Most participants in the study found that PrEPmate was really helpful, both the daily reminders and the weekly check-ins. They wanted to continue to use PrEPmate after the study, and nearly all felt that it would be helpful to offer PrEPmate to all people who were taking PrEP. In the last year or two, we have been working with WellTel. Our initial version of PrEPmate was tested sort of in a steady version that was not built into the current WellTel platform. And so even though Rich Lester was a part of our team, along with Jonathan and Rivet and others, but now that the WellTel platform is really well developed, we thought it'd be great to integrate it back into WellTel. So we've been working with them to do that. And so now we have a functioning platform. This is the red, yellow, green that Cheryl was mentioning, in terms of you can quickly see, in your weekly check-ins, who's doing okay, who's not okay and that needs additional follow-up, or if the messages are not recognized, you can go in and look at those as well. They also flag folks who have not been responding or are overdue. And then here it just shows the screen that's very easy to, you can see the history of communication messages between you and the client. And you can easily just type in messages here and send them. There's also templates that you can have pre-populated and that can save staff time as well. And then this is an example, or this shows the topical messaging, which is basically the fun facts. And so there are different categories that you can include. And basically you can include whatever you want here. We have some pre-populated messages, but people can come up with their own messages that are tailored to their particular clinic or their group. So there's a lot of flexibility here. And the way it works is that they basically rotate through the different categories of messages that go out. And then folks can choose to continue receiving messages. They are scheduled to go out for the first 2 weeks, and then people can say, they can opt in to continue, or if they feel like I got a good handle on it, then they can stop, and then they'll just get the weekly check-in messages. We are testing PrEPmate in a follow-on study that's being tested in several real-world clinics in Miami and Washington, D.C. at the Whitman Walker Clinic, and here in San Francisco as well. And really to see how it works when implemented in more real-world clinics. We are comparing it against another intervention that we've developed called .diary, which is earlier in its testing phase, but it's a mobile app that has been designed to support people taking PrEP, and it gives people feedback on their levels of protection based on their dosing in the last 7 days. And I was just going to mention that as we were talking about costs, that this study has a external advisory committee where we've been talking about planning for early dissemination. And people thought that it was really important to start establishing partnerships with different groups to figure out how we can really make PrEPmate accessible and affordable for all communities. And one idea which I thought was really cool was that people suggested that, you know, there may be bigger clinics that can afford to pay more for PrEPmate. And then there's a lot of smaller clinics or CBOs that may not have that funding. And so there could be some model of sort of a shared model that there's some incentives for the larger organizations to also support access to PrEPmate for the smaller clinics that they are in their area or that they work with. That it could, you know, be sort of a communal sharing of technology to, and the more and more people that are on PrEPmate, it drives down the cost as well because there's economies of scale. So that's something that we've been exploring with them, and as we, you know, start thinking about scaling up PrEPmate. So I think that is it, and I'll stop sharing.
Great, thanks so much, Al. Any questions at all for Al, just about the experience with PrEPmate, and any comments about interest in this? Was this something that, and especially with the jurisdictions on the call, might be of interest to help support local health jurisdictions, CBOs, other clinics to help continue to engage their patients?
Albert, did you have a lot of people stop the messaging, the auto messaging? We used to do a once a month check-in message. And so at the time we had 700 patients. So as you can imagine, 700 responses coming in at one time is not fantastic, trying to go through them. So we actually stopped doing them. Some patients, you know, I think for them, it got to be too much, you know, the messaging. And if you had, we didn't want them to hit stop because then that would stop the communication altogether. But the one feature I will say on WellTel is that you can cater it to people, because obviously, you know, we have people from all walks of life, as I'm sure all the clinics do. There's the one person that's engaged that definitely do not need this, but there are other people that need special care, and you can cater it just to that person where they get, you know, little helpful hints and reminders. Hey, don't forget to do this, which is a nice feature that you can do. So it's not going out to everyone, because we did find that there were some people say, oh my God, stop, please already stop. So we kind of got rid of that.
Yeah.
Just a heads up on that for people. But it's like some people are going, because you don't want it to be annoying, that because we want to keep people engaged, because it's a wonderful way to keep people engaged. But I was just curious if you lost people to that, or if you just do it for a limited time, maybe then that's really helpful too.
Yeah, the model that we tested was just sending the daily run messages were just going out for 2 weeks, and then people could choose whether to continue them or not. And you know, a significant proportion did choose to continue the messages, but some did not want to continue them, and so that was fine. You can, as the check-ins can be changed frequency as well, from daily to monthly, or not doing it at all.
Yeah.
When we did the trans project, we decided just to leave it completely open to people, and they could just choose. You could just have it as an open line of communication with no messaging, or you could get, you know, the weekly or the monthly or the daily, and then people could just choose whatever they wanted.
Yeah.
And we found that worked pretty well.
Yeah. And we found out we were very well loved, because when you send out a message like that, people go, oh, how are you doing? Hope you're doing great. Enjoy your holidays or whatever. So you'd get messages. I mean, we appreciate that. But then when you have to respond to all those messages, it's like, oh, thank you. Oh, thank you. To find the ones that were really important, that was a little bit more challenging. I think that's why we stopped it and kind of catered it to the people that really, you know, need that extra assistance and stuff, that extra little help. But if that was the only drawback about it, that would be the only thing I would say, is that we found we were really liked.
Great. I'm curious, actually, Helen and Kim, just Carolyn, I'm just interested in, and John as well, just interested, is this a kind of solution that you might be interested in learning more about? Could you see a role for something like this. And again, I just want to also just share, Al and I have no financial interest at all in, well, but more just really trying to make sure that this evidence-based intervention gets disseminated. So just wanted to hear thoughts, like, would this be of interest to even just to learn more?
I think it's certainly something to look into more on an in-depth basis, because, you know, checking in with people, especially when they're just starting PrEP, can be really beneficial, because they may not tell you that they're having a side effect. They may not tell you that they have a concern that they didn't bring up when they were in the office. You know, I think a lot of us experience, we get into the office, we have these questions we want to ask and we forget, and then we leave the office, but we don't want to call back. But if someone reaches out, then that opens an opportunity for a conversation for any of those kind of latent concerns to be able to come out. If there's any questions about their medication, dosing it. I also, you know, I think, Cheryl, what you said is so key. You know, we get so many text messages and we get so many emails that sometimes it's like, one more, really? Like, no, stop bothering me. Like, I'm okay. So being really mindful of how often you're kind of implementing these, and asking or letting them know, like, hey, for the next couple of weeks, we're going to send you a check-in. And then after week 4, we won't do it anymore, but you can always reach out to us, kind of setting up that expectation that, you know, maybe this is time limited. I think would be some really good ways to take advantage of a service like this.
I think that's an awesome idea, Kim, because you don't want people to block the service, because it is a really good service. I mean, like you said, because everyone forgets. I forget going when I go to the doctors, you leave and go, darn it, I meant to ask them about that. Where in the moment, people can text in and say, hey, yeah, I am having side effects, or hey, Cheryl, I'm a contact to an STD. Can you get me in, or, you know, whatever, and we can get them taken care of. So it's kind of nice that they have that on hand where they can communicate immediately while it's actually happening.
Any other thoughts before we close, just in terms of the PrEPmate and interest in this kind of model in your jurisdictions?
Yeah, this is Helen from Montana. I think we'd be interested in finding out more about it. We've used kind of a text system for COVID follow-up. And so local people and folks find that really helpful, but you do have to set the expectations up beforehand, because it can get annoying to hear from somebody too often. But I would be interested in hearing more about it.
Great. It's like the Goldilocks rule, right? Not too much, not too little. It has to be just right in order to meet people's needs. So fantastic.
Yeah, absolutely.
Great, great. Well, I know we're at the end of time, so I just want to first thank all of our presenters, Rivet, Cheryl, Al. Thank you so much for your time. Really appreciate excellent presentations and really thought-provoking for all of our participants today. Jesus has shared in the chat the SurveyMonkey link for our evaluation. So please, before you leave, just click on that link, and it'll take you just a minute just to answer a few questions if you find this conversation has been valuable in helping to advance your HIV prevention work. And just want to close and wish you all a happy and healthy holiday season and a happy and healthy new year. And we'll see you all back in January. Thank you all. Really appreciate it.
Thanks, everybody.
Take care, everyone.
Thank you.
That went great.